Etiopathogenesis. So I'm going to talk about it, then after that we'll make some insinuations from that. I mean, brief pathway. Okay. So you should know that there's no exact mechanism explaining the etiology of pre-eclampsia, but there are several theories, or there are several hypotheses, okay, or suggestions to explain that. You can think of in the category of what? Abnormality in placentation, abnormal placentation, okay. We can also think of immunological mechanism. We can also talk about the imbalance between angiogenic factors and anti-angiogenic factors, okay. And then genetic predisposition, that one is very direct. That's why we are even talking about family history and all that, okay. So the first one we'll take, let's take the mostly used mechanism, suggested mechanism is, it has to do with what? Placentation. Are we getting that? Placentation. So we'll start with that one, then we'll add the rest, okay. Now look at how it goes, okay. In a normal pregnancy, okay, there are waves of trophoblastic invasion, okay. Where do you get a trophoblast? From the placenta, okay. In normal pregnancy, there are two waves of what? Trophoblastic invasion. The reason why that happens, look at it. The reason why that happens is to make sure that at the end of the invasion, the maternal spiral arteries, which were originally small and muscular, so in that we say they are small and muscular arterioles, would become larger. They will have large capacitance, means that they will be able to accommodate large amount of blood, large capacitance, and low resistance arteries. Are we getting that? It means that at the end of the invasion, they should become more like what? A funnel. Are we getting that? So to allow for more blood to flow. If there's increased blood flow, they should be able to allow for it to what? Move through into the fetal placenta unit, so that the fetus can obtain maximum nutrition. Are we getting that? That's the normal. We'll delve into details very soon, okay. We want to, at the end of it, the maternal spiral artery, which were initially very small and muscular, will migrate from here to become this. This is a normal pregnancy, okay. That is the reason why there should be what? Trophoblastic invasion. Are we getting that? Are we following? So when the trophoblastic invasion is done, after the second wave, you expect that the muscular wall, okay, the endothelium, and the muscle making up the maternal spiral arteries will become what? Replaced by the cytotrophoblasts. We call them the invading cytotrophoblasts. And they will cause what we call a pseudo-vascularization, meaning that the walls of the maternal spiral arteries have been what? Replaced in a mechanism we call, it's going to be more fibrinogen, okay. Fibrins are going to be deposited, okay. So what is going to happen is that when you have the cytotrophoblast, okay, this is what happens in normal pregnancy. There are two waves of what? Cytotrophoblast invasion. The first one will occur in the first trimester, around 10 to 12 weeks of gestation. Are we getting that? So, meaning that the cytotrophoblast will be invading into the decidua, okay, tonica media. If I say decidua tonica media, it's more like you are looking at, if you say media tonica, means you are referring to a vessel. Okay, the vessels in the decidua. Where do you find the decidua? In the endometrium, true or false? So if I say decidua tonica media, I'm referring to the blood vessel wall. That's the maternal spiral arteries. Okay, the walls of the maternal spiral arteries. The wall. You have these trophoblasts. We call them the invading cytotrophoblasts. They will move into the decidua tonica media of the maternal spiral arteries. Okay, they will start going there. That's the first wave of what? Cytotrophoblastic invasion. The first wave occurs at 10 to 12 weeks. Then getting closer to 16 to 18 weeks, in some jurisdiction they will say 18 to 20 weeks, 16 to 18 weeks, you expect the second wave of cytotrophoblastic invasion to occur. And what is going to happen there? It means that this time around, the cytotrophoblasts would invade into the muscular walls of the maternal spiral arteries, causing a change in the muscular layer. Are you getting that? It will be replaced by vessels. It will be replaced by what? That's why I was calling it a pseudo vascularization. So if you have the cytotrophoblasts invading into what? The walls of the maternal spiral arteries, at the end of the day, the muscle layer should be replaced by something which can stretch. Okay, something that can easily stretch. Are we getting that? Please, are we getting that? So if that happens, it will happen by the end of what? 16 to 18 weeks. Okay, and there are a lot of biochemical processes that are going to be taking place. Look at what is going to happen. When that happens, you are going to see an alteration in a number of what? Classes of molecules. Okay, these molecules that you are talking about, you are going to be thinking of one, the cytokines. Okay, two, you think of what? The metaproteinases. Three, you think of what? The extracellular matrix. Okay, four, you will be looking at what you call the adhesion molecules. Okay, this goes more into biochemistry. Okay, molecular level. Okay, so what I'm trying to tell you is that in normal pregnancy, there are two ways of trophoblastic invasion. And the trophoblasts that invade into the maternal spiral arteries, we call them the invading cytotrophoblasts. Okay, they will start migrating. Okay, they will migrate through the site of implantation. Okay, and invade the decidual tunica media of the maternal spiral arteries. Okay, and that will be in the first wave. They will start migrating through the site of implantation and invade the decidual tunica media of the maternal spiral artery. In the first wave. The second wave, they will have what? Entered into the muscular layer of the maternal spiral arteries. And when completed, when the invasion is completed, you have the maternal spiral arteries, which were initially small and muscular, becoming large capacitance and low resistance what? Vessels. And in that, they will become funnel shape. Okay, to accommodate increased blood flow to the fetal placental unit. Are we getting that? So if there's any disruption in the invasion such that there's inadequacy of the cytotrophoblast invasion, then what are you going to have? You will see that the walls of the maternal spiral arteries will remain intact. They will remain intact and they will have high resistance to blood flow. Are we getting that? And if there's high resistance to blood flow, what are you having? You are going to have what? What are you going to have? You are going to have more of what? Vasospasm. There is going to be intense vasospasm. And when there's intense vasospasm, what happens to the vascular resistance? It will increase. And what will happen to the blood pressure? It will increase. Are you getting that? But if the second wave of trophoblastic invasion occurs without any deficiency, you will see the small muscular spiral arterioles becoming what? Large capacitance, low resistance, high flow arteries, where they will be assuming the shape of a funnel. Are we getting that? Please, do you get that? Do you get that? Yes. Okay, now let's take that one. Let me diagrammatize that one for you. So you should know that in normal pregnancy, there are what? Two ways. of trophoblast invasion. Okay, that is the first wave at 10 to 12 weeks, and that will be in the first trimester, and second wave at 16 to 18 weeks. And I said at 16 to 18 weeks of gestation, and I told you in some jurisdiction, in some places, is what, 18 to 20 weeks. So the ideology is that trophoblastic invasion should be completed before 20 weeks. Are we getting that? It should be completed before 20 weeks. If it's persisting beyond 20 weeks, then definitely we'll be seeing hypertension after 20 weeks. Are we getting that? But if it does not persist, it's completed before 20 weeks, you will not have hypertension after 20 weeks. That's when we say that it's chronic hypertension. But if the invasion is persisting beyond 20 weeks, it means that there's a problem. Are we getting that? So in normal pregnancy, there are two waves of trophoblast invasion. Okay, first wave at 10 to 12 weeks, and second wave at what? 16 to what? 18 weeks. And the next thing we can say is that, okay, at the end, so in this case, we'll say that the invading cytotrophoblast. So the trophoblasts that invade into the maternal spiral arteries, we call them the invading cytotrophoblast. Okay, the invading cytotrophoblast migrate through the site of implantation, and invade the decidual tunica media of the maternal spiral arteries. Okay, the invading cytotrophoblasts migrate through the site of implantation and invade the decidual tunica media of the maternal spiral arteries. Okay, causing a transformation of the spiral arteries from small muscular arterioles to large capacitance, low resistance, large capacitance, low resistance vessels. Okay, so we'll say that here we'll say that it's final shape. It becomes final shape. That's what I drew on the board for you. At this point, it becomes final shape. So in this case, what I mean by this is that it will be able to accommodate large amount of what? Blood. Okay. It will be able to stretch. It will not be what? Intact. Are we getting that? Are we following? Are we getting that? Are we following? So this is the normal physiology. This is the normal physiology that we are seeing. Okay. At the end of the invasion, okay, at the end of the invasion, we should see the small muscular arterioles becoming what? Large capacitance, low resistance vessels. Is that clear? Is that clear? Large capacitance, low resistance vessels, which will assume a final shape, improving blood flow to the fetal placenta unit. Okay, it means in this case the spiral arteries will not be intact and they will not become narrowed, because if the muscles are there, definitely they'll be narrowed. Are we getting that? So the muscles are not there. So it's able to what? Distend in response to increasing blood flow. And that will allow sufficient blood flow to the fetal placental unit. Is that clear? And what happens here? See, the mechanism here is very broader. It's broader than you think. Okay? When they invade into the decidual tunica media of the maternal spiral arteries, there are a lot of alterations, as I told you, in what? Classes of molecules. And I told you the examples. I told you about the adhesion molecule. I told you about the cytokines. I also spoke about the extracellular matrix, and I also made mention of what? The metalloproteinases. Metalloproteinases. Are we getting that? Metalloproteinases. They are going to ensure that the muscular layer of the maternal spiral arteries undergo transformation to become more elastic. They are going to ensure that the muscular layer of the decidual, or basically the maternal spiral arteries, will become replaced. Okay? And you should know that the process by which the invading cytotrophoblast, okay, causes a change in the endometrial lining. Okay? No, not the endothelial. Sorry. It causes a change in the endothelium of the maternal spiral arteries, okay, such that it becomes large capacitance and what? Low resistance. We call that what? Pseudo-vascularization. Okay, pseudo-vascularization. The moment you are having invasion by the cytotrophoblast, causes the spiral arteries, that's small muscular, to remain intact. Okay, remain intact, resulting in intense vasospasm. Okay. In this case, we say that the vascular resistance increases. Vascular resistance will increase. And what will happen? There will be what? Hypertension. Are we getting that? So this is one of the pathways. Okay. You should know that anytime the cytotrophoblast invades into the decidual tunica media, okay, to cause a change in the wall of the spiral arteries, we call that pseudo-vascularization. I told you that already, pseudo-vascularization. Please, we get this. This is one of the theories or suggested mechanisms to explain pre-eclampsia. There's another one that we can talk about. So this is one of them. Another one, we can talk about imbalance between androgenic factors such as we have what we call vascular endothelial growth factors and placenta growth factors. Vascular endothelial growth factors and what? Placenta growth factors. What this does, I told you about pseudo-vascularization, right? These vascular endothelial growth factors and placental growth factors, when we bind to the vascular endothelial growth factor receptors, okay, they enhance the migration of the invading cytotrophoblast into what? The decidual tunica media. So with these growth factors, they will make sure that what? The invading cytotrophoblast reach the decidual tunica media off. the spiral arteries. Are we getting that? Are we following? So imbalance between angiogenic factors, that is vascular endothelial growth factor, and what? Placenta growth factor, and anti-angiogenic factors. Yes, we know some of them. That one is, I would say, school of further studies, but it's not true. So we'll call it SFLT and XN. So the first one we call it soluble FMS. This one is soluble FMX like tyrosine receptor 1. Tyrosine 1 receptor, tyrosine 1 receptor. So this one we call it SFLT1. Tyrosine 1 receptor. And this one we call it soluble endoglin. Soluble endoglin. Okay. Soluble endoglin and soluble FMS like tyrosine 1 receptor. The two, they are anti-angiogenic. Are we getting that? So the imbalance here, it means the angiogenic factors will be what? Reduced. Okay? And anti-angiogenic factors will what? Increase. Take note of that. The imbalance that I'm talking about is with respect to, it's going to favor the anti-angiogenic. If the blood is not flowing sufficiently, what are we going to have? We are going to have what we call in that release of what? Usually there should be hypoxia-induced release of what? The growth factors. Okay, the endothelial growth factors, as we are seeing. But again, there is going to be what? A dysregulation in the release of these growth factors, such that the anti-angiogenic growth factors will dominate over the angiogenic. So this particular mechanism, it has this kind of crisscross effect with the others that we've spoken about. But in short, we will say that if there's an endothelial injury as a result of an inflammation, as we said, leading to platelet activation and aggregation, what is going to happen? There's going to be what? A decrease in the luminal diameter of what? The spiral arteries, increasing the vascular resistance, leading to what? Hypertension. Is that clear? Is that clear? Okay. There are other pathways like the genetic predisposition. I mean, that's another mechanism, genetic predisposition, and so forth and so on. Please, is that clear to you? So the main one is this one that we spoke about. But we can also add this and the other one that we made mention of. Please, are we clear on that? Are we clear? So pre-eclampsia has to do with what? Inadequate or incomplete cytotrophoblast invasion. Okay. At the end of the second wave. Okay. So 16-18 weeks, we expect it to be complete so that we can have the spiral arteries assuming a funnel shape. They will become large capacitance, low resistance vessels. But if the invasion is not complete, the arteries, the spiral arteries will remain intact. They'll be small and muscular, and they'll become high resistant vessels, decreasing flow of blood to the fetal placenta unit. Is that clear? Please, are we clear on that? Okay. So, plus pre-eclampsia, simply we can say that there is a what? It's as a result of what? A defective, okay? A defective, as you can see, a defective vascular what? Yes.
Now, the risk factors are then getting pregnant for a new husband. This is the risk factor.
Which one?
For the risk factors. Ellen getting pregnant for a new husband.
For a new husband. So it means that the woman has married before. Yes, that's why I told you about the paternal antigen in recognition. Remember we spoke about immunological. And I was telling you that the paternal antigen that will come from the sperms, if it's not well expressed and shared by the maternal immune system and the fetal immune system, then it means that the fetal antigen will not be recognized by the maternal immune system. Are you getting that? And even the placenta. So there's going to be what? That release, that attack, antigen-antibody interaction, causing the release of what? The, as we were saying, the type 1 T helper cells, okay, causing injury to the endothelium, leading to activation of platelet and aggregation, okay. Okay. Another thing that we can also talk about here, which is very interesting as a mechanism, is we can also make reference to the imbalance between the production of prostaglandins and what? Thromboxane A2. There's also another pathway that we can look at. The prostaglandin, if I say prostaglandin, it's also known as prostacyclin is what? Prostacyclin is what? Prostaglandin I2. Prostaglandin is what? Prostaglandin itself is what? E2, yes. So that's what I'm asking. So it means that if you have a lot of prostaglandins, they will enhance dilatation, vasodilatation. Are we getting that? Are we following? Another pathway, another physiological way by which the spiral arteries, okay, in relation to pregnancy maintains their large capacitance in a normal pregnancy is by ensuring, anytime a woman is pregnant, the placenta releases a particular enzyme. What's the name of that enzyme? We call it what? Angiotensinase. So the angiotensinase would ensure that what? Angiotensin is destroyed. And it will also cause refractory inhibition in the response to what? Vasoactive compounds. Okay, so it means that if there are vasoactive compounds present like angiotensin 2 and all that, trying to have an effect on the muscular wall of the spiral arteries, they will resist. Are you getting that? And if the placenta is producing angiotensinase, okay, to break down or lyse angiotensin 2, do you expect the blood pressure to go high? Do you expect it to go high? It will not, because the RAS mechanism, we spoke about that, is one of the most important contributors to what? Increased blood pressure. So if there is high level of angiotensinase, of course angiotensin will be broken down at all points. Are we getting that? And again, if there is what? Refractory insensitivity of what? The endothelium of the spiral arteries to vasoactive compounds, it's also another physiological means to ensure that blood pressure doesn't just go up by heart. Is that clear? Is that clear to you? Okay, let's move on.